Hi, I'm Dr. Michael Latola, and I'd like to welcome you to this clinical presentation from Glidewell Laboratories. On this presentation, we're going to take a look at three techniques. The first is the reverse preparation technique, and we found a couple of years ago how valuable it would be if we could give our dentists a technique that would ensure adequate and consistent reduction. And this technique works for PFM crowns, all ceramic crowns, and even cast gold crowns for that matter. The second technique is a rapid anesthesia technique that works particularly well on mandibular molars. If we're going to do a full arch or a quadrant, we'll still use block anesthesia. But as I walk through the laboratory, I see a lot of models where only one or two mandibular molars have been prepped. And this technique is going to be very helpful to you in those types of situations. Lastly, but certainly not least important, we're going to take a look at impression technique. I don't think there's anything that we do as dentists on a daily basis that has as much of an impact on the quality of our restorative dentistry as taking impressions. We're going to walk through the lab and look at some unacceptable impressions and see if we can find why they're unacceptable. And then I'm going to show you the two-chord technique that I've used for the last 8 to 10 years, and it has allowed me to take near-perfect impressions on a daily basis. Let's get started. Now let's go ahead and take a closer look at the rapid anesthesia technique. This is Profound that I'm holding in my hand. It's available in a syringe or a tube. If you want to use the syringe, you have to order these disposable syringe tips. We get these from Ultradent, and we put these into place on the front of it, and then we can inject this material around the sulcus of the tooth we're going to work on. It's probably a little bit easier to order it in the tubes and just use it on Q-tips, because then you can use it adjacent to anterior teeth and things like this. Actually, it's probably a better idea to have one of each. The tube for the anterior teeth and the syringe for back here. And you can see how we're expressing this material around the sulcus of a lower molar that we're going to anesthetize. Now, the reason we're using the rapid anesthesia technique is that we do not want to give a lower block here. We only need to have this one tooth anesthetized. And with lower blocks, we know from personal experience that these are the injections that dentists tend to miss more than any others. So rather than give a block and maybe not hit it and have to wait and numb everything on the patient, patients are actually really happy when we can numb individual teeth, which includes mandibular molars, as we're doing here. So anytime I'm doing a single mandibular molar, or even the two molars, I will use this rapid anesthesia technique to anesthetize those molars. Now, the anesthesia with this technique does not last as long as a block, but you typically don't need it to, because as soon as you're done with the rapid anesthesia technique, you can set the syringe down and pick up the handpiece and begin working. So it keeps you on schedule because you're not waiting to see 10 minutes to see whether or not a block worked and then having to re-inject later. And the funny thing is, when you do go to re-inject later, this is typically what we'd give is an injection like this. And one day my dental assistant said, well, why don't we just do this right off the bat, this type of injection? I said, that's a really good point. So we've got the Profound in place around the molar. It begins to melt and kind of work its way into the sulcus. And that's really all we're trying to do, is get some anesthesia in and around the sulcus. This is a regular aspirating syringe that I have in my hand with a 30-gauge extra short needle tip on here. We've got some Septicane in there. Septicane works extremely well for this because of how highly it's absorbed across membranes in the body. And you can see I've put a 45-degree angle bend in that needle, and that red dot signifies the part of the needle where the bevel is, and so we want the bevel in contact with the bone, or in this case with the inside of the furcation. So once the Profound has had a chance to soak in for about 60 seconds, I enter the furcation from the buccal at a 45-degree angle, really trying to get the tip of my needle into the furcation of this lower molar. I know there's a furcation there because I've seen it on a bite wing x-ray. As you express this slowly, it takes time for the anesthetic to be able to be accepted into that PDL space. And as you can see right here, I've got a little extra injection anesthetic coming out, so my assistant will typically have her slow-speed suction or a cotton roll back there, because with this type of injection, you will get some anesthetic material kind of spilling up from the sulcus, and it really does taste horrible, so we'd like to be able to help the patients with that. So it's a little easier to see sometimes on an animation. So here we are placing the Profound on the gingival sulcus. As it reaches body temperature, it gets more liquid and it begins to slide subgingival. I've seen dentists use an Explorer to kind of help that happen as well. We just want to get some initial topical anesthesia there so they don't feel the needle. Again, we're bending away from the red dot so that the bevel is going to be facing the medial aspect of the molar. So it's going to go into place here through the profound if there's any left, and then just slide through the gingival sulcus as far as it'll go at a 45-degree angle, because we really want the tip of this needle to get into the furcation if possible. So as the needle travels down, you can see as we remove the bone from this animation where the tip of that needle is sitting between the furcation with the anesthetic heading towards the mesial of that tooth. As we begin to slowly express the septicane, and recall that with septicane in this technique, we only need to use about 1/2 to 2/3 of a carpule here. So it's not our intention to get 1 or 2 or 3 carpules down into this furcation. And as you can see in the animation here, the local anesthetic, the septicane, is represented by the blue, and it begins to travel down the PDL towards the apices of this molar, where we're going to get some anesthesia there. But more importantly, and the reason why we have the bevel facing up, is that the anesthetic is going to travel up through these nutrient canals in the base of the furcation into the pulp, a more direct route than numbing the PDL down towards the apices. And of course, one of the huge advantages of the rapid anesthesia technique is as soon as I set down the syringe, within 15 seconds, so it really saves a ton of time, because I give the rapid anesthesia, I prep right away, we get the cords in, and all we need to do then is take the impression and make the temporary, and the patient's basically done. So, instead of scheduling an hour and a half for a crown prep, now they can be scheduled for 45 minutes, because I'm not waiting on a block, and we can start as soon as the rapid anesthesia technique is completed. As we fly through the burr kit here, this is the reverse preparation technique burr kit, available from Access Dental through any and all dental dealers, which is based on this technique you're about to see. This technique was born of frustration, in the sense that as I walked through the laboratory and looked at preps and impressions from dentists, the one thing that I noticed was a lack of consistent and adequate reduction on almost all preparations. That included my own. And began to look at the reasons why that we would under-reduce, yet at the same time demand great-looking crowns that blended in with the surrounding natural dentition and had nice aesthetics as well, because it doesn't make sense to under-prepare if that's what your goal is, to do some aesthetic, quality, restorative dentistry. And as it turns out, I just noticed on my own that as I started to prepare teeth, once you take that dime into a tooth, you lose all perspective of where you were, unless you're going to go to a lot of effort to make some sort of polyvinyl matrix that fits over the tooth so you can see how much reduction you did or something like that. It's really difficult to tell how much you reduced. And so I sat down and came up with a preparation technique based on depth cuts, so that there'd be no question in my mind or your mind how much had been reduced. And really, when you do a preparation based on this technique where you are using depth cuts as a guide, if you don't get great looking restorations back from your lab, you really can say to them, hey, what's going on? I gave you enough room. We should get something back that matches the tooth next to it. Of course, you need to send in some digital photographs so they can see the tooth that they're trying to match, and some other stuff. But you can really be a little more demanding with the laboratory when it comes to what your lab work looks like. So here's a case. You can see we've got a pre-existing PFM crown on tooth number 8 the patient doesn't like. Tooth number 9's got some incisal chipping, and we're going to put crowns on both those teeth and then supplement it with some no-prep veneers to round out the rest of his smile. We start the anesthesia technique with some Profound from Stevens Pharmacy. This is the strongest topical known to man, or at least known to me. And leaving it in place for 45 to 60 seconds, the patient will not feel the needle go through. I still do a little lip shaking here, but it's really not necessary. And we give a few drops of anesthetic, wait just a little bit, and then continue to give. This is Septicane that we're using because it absorbs so well. And really, one of the great things about the Septicane and its high absorption is we've noticed that we no longer have to give palatal anesthesia while packing cord. We can pack cord around the entire circumference of the tooth, and we don't need to give any local on the palatal because the Septicane really seems to give us enough anesthesia over there to do it. In cases where the palatal tissue is really sensitive, we'll just take a little more Profound and squirt it around in the sulcus and then rinse it off and dry it and then place the cord back there. So Profound has really kept us from having to do any palatal anesthesia anymore, which is nice. Since we have an existing PFM on tooth number 8, we need to take that off. So I'm using here a razor carbide from Access Dental, again available through any and all dental dealers. And the great thing about this burr is just how it flies through the crown. I'm actually going a little bit slower than usual here because we're on camera and I'm trying to keep the porcelain as I'm cutting it out from filling up that groove and ruining the shot. But this thing flies through porcelain and through metal, including base metals, and so it's just a great way to zip through a crown in about 5 to 10 seconds. There's a Hugh Freedy Christensen crown remover being used to pop that off. Just the fastest way to get through a PFM, especially compared to the old diamond and carbide that I used to use for years and years. Step 1 is going to be breaking the contacts in the reverse preparation technique. It's a single carbide burr of 56 that we use to break the contacts if we're not preparing the adjacent tooth, as we see here. So the 56 is being used on the distal of tooth number 9. Since we are not going to touch the mesial of tooth number 10, that's going to be a no prep veneer, not a prep veneer, so we don't touch it. If we're prepping both teeth and they're unprepped, as we see here in this animation, we use our 856-025 to break the contact. And by doing this, we not only break the contact down to the level of the gingival papilla, but we begin the interproximal margin formation on both those teeth as well, and we get most of the reduction out of the way. So it is really nice when we're preparing adjacent teeth because we can take that bigger burr through and break the contact and start the margin formation all at the same time. But of course, if you're just prepping one tooth and not the adjacent one, the slender 57 carbide burr is the best way to accomplish that. Here on the mesial of tooth number 9, I'm using the 856-025 anyway, just because I want to get my depth right, and I know how that burr has to sink in for me to be able to get that right. Step 2 in the reverse preparation technique is the placement of the first cord. This is a size 00 cord from Ultradent. You can see me floss it in interproximally on the distal of tooth number 9, and then I'm going to floss it in on the mesial of tooth number 9 and pull both ends to the lingual. So it's tacked down on both sides, and really all I have to do here now is get that cord down into place in the facial sulcus. Really, this whole thing, putting this first cord in, should take no longer than, say, 30 seconds. Because it's really just a simple pushing down on the facial, a little more difficult on the lingual. We cut one end and get a loose end because it's easy to tuck that loose end in, and we get that end all the way down. Then we begin to tuck the cord in from the other side, and when we get close, about a millimeter away, we'll go ahead and cut that with our scissors and then tuck that other loose end subgingivally on the lingual. We'd like those two ends to kind of butt up against each other, but this cord is so small that if they overlap a little bit, do not worry about it at all. Once that cord is in place, when you look if you could look carefully maybe at the CEJ or any staining on the tooth, you'll notice that you have had some retraction of the tissue, and this initial retraction of about 0.5 millimeter to 0.75 millimeter is provided by that first cord that goes in place. And since that tissue has now been moved back, it's time for step 3, the preparation of the gingival margin. This is really kind of the heart and probably the most important step of the reverse preparation technique, is the use of this round burr to form the gingival margin. It's important that it's a round burr, and it's important that this step is so early in the technique as well. So if this is one area where you really don't want to change anything in this technique, because this is kind of where the magic happens. This is an 801-021 burr, the 801 referring to the fact that it's a round burr, and 021 for the 2.1 millimeter circumference of this burr. And as we use it around here, it cuts a perfect half circle into the tooth because we're sinking in at about halfway. And it's a 1.25 millimeter depth cut into the tooth right above the level of the gingiva. And then you take that and you do that on the lingual as well. And this is really, if we're doing this on the lingual, this is going to be an all-ceramic crown. Probably a zirconia-based crown, like a lava crown from 3MSB or a CZ, a prismatic CZ crown. Something like that. If you're going to do a PFM that's got a lingual metal margin, you do not have to prepare a 1.25 millimeter reduction. You could do a 0.5 millimeter. You'd probably get away with a little bit less than that if you're going to have a true metal margin or a metal lingual. But I want to show you a prep technique that is universal in the sense that it could be used for anything from cast gold to PFM to all ceramic crowns. And with the placement of the 1.25 millimeter depth cut on the lingual, It can be used for anything, including all the new cementable all-ceramic crowns that are proven to be very popular with dentists. Step 4 is the incisal edge depth cuts, and you really need to put a little thought into this before you make this depth cut. For example, on this tooth that you see right here, tooth number 9, it's a little shorter than usual. This tooth is 10 millimeters long, but after discussing it with the patient and looking at a diagnostic wax-up, we have decided to keep it at 10 millimeters long. That's going to be the final length of our restoration when it's on this tooth as well. So as a result, we're placing a 2 millimeter depth cut into the incisal edge of this tooth because it's going to take our technicians 2 millimeters to build an authentic, natural-looking incisal edge for us. Now, if this tooth were 9 millimeters long and the final length was going to be 10 millimeters, we would only have to do a 1 millimeter depth cut, and the laboratory would just take the tooth. The prep tooth would then be 8 millimeters long, and they would add 2 millimeters to it to make it a 10 millimeter long tooth. So don't just hop in and do 2 millimeter incisal reduction on every tooth you're doing, because that's what you saw me do on this particular tooth. You need to start with the end in mind. How long is this central incisor going to be? And then use that to figure out how much of a depth cut you need. If this tooth is 8 millimeters long, and the final length of it's going to be 10 millimeters long, you don't need to do any preparation at all. They can just simply add the 2 millimeters. You can just smooth off the incisal edge and round it off for them. So we've got the gingival depth cut done now with the round burr. We've got our incisal edge depth cut. We're going to use another one of these MADC burrs. These are self-limiting depth cut burrs. So when you push these depth cut burrs into place, they cannot go deeper than, in this case, 1.5 millimeters. And in dental school, I was taught to make these depth cuts with a 330 burr. One of the problems with a 330 burr is if you push it, as it falls, through the DEJ, it'll keep going, and there's nothing to stop it. And that's what I like about these MADC burrs, is as you push them down into place, they bottom out, and they will not go any deeper. So you cannot place depth cuts that are too deep. They're always right at the depth you want. So if you look at this here, we've got our gingival depth cut of 1.25 millimeters done by the round burr. We have our axial depth cut of 1.5 millimeter. You can see that dark spot in the bottom of that facial axial depth cut, and that's because that burr was starting to get dull, so that'll be tossed now. And then you can see the 2 millimeter incisal edge depth cuts from the MADC, the 2 millimeter MADC burr. And so now really we've got all our reduction built into this prep. And now it's just a race to see how quickly we can get all the enamel off. It really is. And that's step 6, blending the depth cuts. Once we've got a marker everywhere of how much reduction we need to do, it does become how quick can we get all this tooth structure off of here, because now we know exactly where we're going. We have depth guides showing us exactly where to cut. There's no question where to cut anymore. And for me, that's a simple way to prep more efficiently and prep more quickly, to prep more accurately, and to get better restorative results. In fact, I kind of kick myself for not using a depth cut based prep technique like this earlier in my career, because I was searching for another way to do it, and there isn't another way to do it. Step 7 is the lingual reduction, where we're taking a football burr and we're going to go in and prep everything from incisal edge down to our gingival depth cut. This is a 379.023, a standard turbo grit football burr, and you can see our preparation already starting to take shape. Patient bites together. Again, that football burr is a convex burr, which is great because it cuts a concave surface for us on the lingual. And I don't see enough concavity on most of the lingual preparations of anterior teeth we see here in the laboratory. Remember, the initial surface, or the natural lingual surface of those central incisors, is in fact concave in the beginning. And if a dentist doesn't prepare it enough, you end up getting crowns back with no lingual anatomy whatsoever. And it's ugly, it affects phonetics, it probably affects function in some way, certainly protrusive paths. It's not supposed to be there. So make sure you use a convex burr, like a football burr, to ensure that you get a concave prep surface. This is the one area where we don't need a depth cut. We have the opposing teeth, and we have maximum intercuspation to show us how much we've reduced if we have checked the bite beforehand. So we don't place a lingual surface depth cut because that's what the opposing teeth are there for us to do. But if you look on the facial surface of, say, tooth number 9, there's no way for us to kind of know how much we've reduced unless we've placed that depth cut. And you can see at this point the depth cut is gone. And really by following those depth cuts, you can see the nice shape of the preparation that we have there as well. It's really started to take form. Step 8 is the placement of the top cord. This is a size 2 cord from Ultradent. And I just pull it down in one area. I start here on the distal of tooth number 9 and pull it straight down into place. I don't floss it back and forth. I don't want to upset the cord that's underneath it. And then we just slowly work around. And boy, you can really see as we go around there the exposure of the gingival margin. Now the goal at this point when we put the number 2 cord in is not to drop our margin down even farther. Because remember, when we take these 2 cords out, the gingiva is going to rebound to its original position, leaving this margin subgingival. Because we put the 00 cord in first and got about, on average, 0.5 millimeter of gingival reduction, and then we took our round burr, cut down to that level, we're going to end up, when we take that 00 cord out, with a margin that is approximately 0.5 millimeter subgingival. That I'm comfortable with. That's far enough subgingival where it's not going to cause perio problems, yet it is far enough subgingival where you're not going to see the root shade and the crown shade coming together. But to put this cord in, this top cord, this number 2 cord in, and then drop the margin, the gingival margin down to that level, that would leave us with a margin that would be about 1 millimeter to 1.5 millimeters subgingival. And I'm not totally comfortable with that, except in very certain situations, patients who physiologically or psychologically can't keep their teeth clean. Then I will, bury those margins a little bit more. But you can see how visible the margins become here. And that's important because we're going to go in and do some smoothing of the margins. Our goal is not to drop it any farther, just to smooth it off and give the laboratory the best looking margin we can, so we end up with the best fitting crown that we can and have something that's not susceptible to, say, open margins, recurrent decay, and all that bad stuff. We trim one side of the cord, and again, we're going to pack that free end down. We don't really need to pack both ends of this cord flush. We'd like to keep one end exposed, so when it comes time to take the impression, we have something to grab onto. So we tuck it down most of the way. You can tuck it down all the way and just fish it out with an Explorer as well. That's not a big problem. Step 9 is finishing the gingival margin. In that animation, we've got a red stripe fine grit burr that's in there. That's a great way to do it. Here's another way that I like to do it. This is a system. It's a sonic scaler that you would use to, say, an ultrasonic scaler that you would use, say, to clean teeth or something like that. And I have a fine grit diamond tip in it. This is a system available in Germany now, be available here in the U.S. Soon, and you'll see them advertising it. Here I'm using it on the incisal edge as well. You can do this with a sandpaper disc. We need to round off those incisal angles so we don't have sharp edges there. And the reason we don't want sharp edges there, even though we'll be able to catch those sharp edges in the impression, when the laboratory goes to pour up that master model, when they remove that model from the impression, if we've left sharp corners in our preparation, there's a chance that even using good die stone, that the little corners of that model are going to break off inside the master impression. Then once the model comes out and has the die spacer painted on it, no one will ever see, and we'll make a crown for you that fits great until you go back to the mouth where you have those little pieces of tooth that are still in place, and now the crown doesn't fit. So if you get anterior crowns back from the laboratory and they go down almost all the way but not all the way, the first thing you should do, take out a sandpaper disc and round those incisal line angles where things are still a little sharp. You should do that before the impression as well, as we just did here, just to make sure that going into it you don't have that problem. But if you do have those fit issues, head right for those. And of course, after you've looked at everything else, like there's no temporary cement remaining on the tooth or anything like that, oftentimes smoothing off those incisal edge angles will help it for the crown to seat the rest of the way. So just going through here and smoothing everything up as much as we can here. No need for any big diamond marks there. We want something that's easy to read in the impression and easy for them to work with when they're taking a wax coping on or off, if it's a PFM, or with the zirconia coping if it's going to be an all ceramic crown. Step 10 is the placement of the anatomic compra caps. The original compra caps look to be just like a cotton roll that the patient would bite on. The anatomic part refers to the fact that there's cutouts on the mesial and the distal, so that in the areas where the interproximal papilla goes up, the copper cap goes up with it. So not only does it avoid putting too much pressure on the interproximal papilla, it allows the copper cap to slide down more and give you good pressure on the facial and lingual tissues as well. And so these copper caps really are fantastic. I mean, in some cases where you're doing an emergency crown and the patient hasn't been through hygiene yet, you're looking at it thinking, oof, I do not want to impress this today. If you put these copper caps on and have the patient bite down on it for 8 to 10 minutes, they will work miracles. You'll come back in after 10 minutes, take off the copper caps and look down and say, boy, I can't believe that's the tooth that was bleeding when I left the room 8 to 10 minutes ago. And they really do work their magic. 8 to 10 minutes is a good period of time. And I'm serious about that. I don't just wait 2 minutes and then take an impression. I go out and do a hygiene check or see another patient or whatever needs to be done, even go make a phone call, because the 8 to 10 minutes we see great things happen. And you can see how nice these teeth look right here after that same 8 to 10 minutes. So we're going to remove this top cord. You will see no bleeding here, or you should see no bleeding here, I should say, because in this 2-cord technique, as long as that bottom cord stays in place along the inflamed base of the sulcus, there will not be any bleeding. When that first cord comes out, there will be bleeding. We go around the prep once, 2, 3 times, once, twice, 3 times around the prep, twice around the gingival margin, just to make sure that any air or especially fluids that are in there get driven out. You can see we go back and forth across the length of the entire arch because we want to make sure that we get all those teeth, because we're doing some no prep veneers in conjunction with these crowns. And we've taken the impression. Let's take a closer look at that. And that's really what an impression is supposed to look like. If you look at the tooth number 8, the tooth on your right on the screen, you can see that we've got a nice thick area beyond the margin all the way around the tooth, and that is critically important. Yes, we can see the margin all the way around the tooth too, and that's certainly important, but it's that extension of material beyond the margin that for me makes this an almost perfect impression, or a seemingly perfect impression, because when you have material beyond the margin, then the technician knows for sure exactly where the margin starts and where the margin ends. And that impression beyond the margin is really an impression of the root surface of the tooth. And so that gives them a ton of critical information about emergence profile. And all of a sudden you have the opportunity to have a tooth that really looks like a tooth and is periodontally sound. My assistants go ahead and placing the bite registration on this arch. This is actually more than you need. Really, the bite registration should just be on those 2 prepared teeth, teeth number 8 and 9. She's extending a little bit farther for the no prep veneers, but they'll be able to get the bite from 8 and 9. So really, anytime you're doing a bite registration for the laboratory, just get it on the teeth that have been prepared and the opposing teeth across from the prepared teeth. In fact, you really only need it on the incisal third of the prepared teeth and the incisal third of the opposing teeth as well. That's more than enough bite registration because we're going to trim it back. Now it's time to make the temporaries. We have taken a pre-impression with an alginate substitute material in a disposable tray beforehand, and we're placing our Luxatemp in place and wiggling the impression out. And because these are crowns, we will, of course, be able to remove those. We've got some flash here that we need to peel off. We don't need to do any temporaries for the no prep veneers, which is nice. So we're going to just get this flash off here, wiggle off these temps, polish them up, and put them back to place. And 2 weeks later, we have the patient back, and here's a look at those 2 crowns in his mouth. Those are CapTech CAD-CAM crowns on tooth number 8 and 9, and then the surrounding teeth have no prep veneers, and you can see it's a big difference from before to after here. This wasn't the easiest case in the world because the patient's got a real kind of facial flare to those maxillary teeth, very tight musculature, just to try to get him to smile and show any teeth was tough. He was constantly popping the retractors out of his mouth because of how tight and how strong the muscles around his mouth were. So that's about as much of a smile as we can get out of him. But you can see as we look at this final smile that how nice everything kind of blends in together. And that really is important because if we had just done the crowns on tooth number 8 and 9, you would not see this whole smile blending together quite like this, most likely, because the other teeth did have some minor aesthetic issues. However, the patient was not excited about and did not like the idea of having the teeth prepped for veneers. This is one of the reasons why on these DVDs and in my lectures I've been talking about how no prep veneers, the V veneers that we do here, really are great for finishing out a smile. because for somebody who does want to do their whole smile but doesn't like the idea of having all their teeth prepared, or this is a great way, especially in a case like this where you're doing 2 crowns, to be able to let somebody know, hey, we could take these veneers without doing any drilling or anything and put them on the teeth next to it and show you how it looks. And it really does turn out nice for them. In fact, we have a diagnostic wax-up DVD where we do that, and we show somebody ahead of time what that looks like. If you'd like to take a look at that DVD online, or if you'd like to go ahead and have us send it out to you, you can see what that looks like, and you can show somebody ahead of time what no-prep veneers will look like in their mouth. For posterior teeth, the reverse preparation sequence essentially follows the same steps. In this case, we're not preparing either of the adjacent teeth, so we're using a 57 carbide burr to break the contacts on the mesial and the distal of this molar. And then once the contacts have been broken and we've achieved separation between the teeth, we're going to place our first cord. This would be the 00 cord, and this is going to go into place. I will typically floss it in place on the mesial and distal by hand and then pack it to place with an instrument. We're showing you this on an illustration because it's much more effective just to show this on an illustration than it is by actually preparing it. The next step, of course, is the preparation of the gingival margin with our round burr, the 801-021 burr. And again, the burr is being held as perpendicular to the long axis of the tooth as it can be, and then taken to half of its depth, the farthest it'll go in. And we cut our margin on the facial and the lingual. We're going to go ahead and make some depth cuts using the MADC burrs that you'll find in the reverse preparation kit. This is the one that has 4 rings on it, the MADC 2.0, the 2 millimeter depth cut burr. And you can see we're making sure that we hold the tip of the burr perpendicular to the tooth surface as we make these depth cuts in the top of the tooth. So we've got 1 in the central groove and then 1 in each of the cusp tips. This is the 3-band 1.5 millimeter MADC burr. We make our axial depth cuts with this. By the way, that gingival depth cut we've already made is 1.25 millimeters deep. And those are the recommended reductions that we'd like to have for any PFM or any all-ceramic crown as well. 2 millimeters on the occlusal surface, 1.5 millimeters on the axial surfaces. And by virtue of the use of the margin creation with the round burr, we've got a 1.25 millimeter one. In reality, we see under reduction by dentists in all these areas, and we really need to try to stick to these numbers to get back some functional aesthetic restorations. Here we're using a large burr. This just happens to be an 856-025, one of my favorite burrs, to connect all those depth cuts on the occlusal. And that's literally what we want to do, is make a swipe across and make sure we don't see any signs of the most apical part of those depth cuts after we've made that reduction. We're then using the 856-025 to blend our axial depth cuts. At this point, I really try to cut these walls straight up and down. I don't try to get any taper in here. I want to cut it straight up and down because as I move along the prep technique and blend these axial planes a little bit further, I'll get the correct taper. So in my mind, I really want to cut this prep straight up and down, or maybe even undercut it a little at this point. Anytime we cut with a burr in opposing planes like this, we're going to end up with some sharp edges. Here we're using a 3M SB Soft Flex disc to remove those sharp edges. Very important to get restorations back that fit, that we remove those sharp edges. Here's placement of the second cord. This is a size 2 cord from Ultradent being put into place on top of the 00 cord being packed down. The 00 cord, as long as it stays in contact with the base of the sulcus, when we pull that top cord, we will not have any bleeding. Very important that we put a copper cap on top of this preparation once both the cords are in. This is an anatomical copper cap with the little cutouts in the interproximal areas. We're going to place this over the prepared tooth. The patient's going to bite down on this for 8 to 10 minutes. And by using this 2-cord technique with the copper caps, I can honestly tell you that we have bleeding when we take an impression maybe 1 out of every 20 times, and that's typically pretty minor. In this section, I'd like to take a closer look at some impressions with you. We'll take a look at some highly acceptable impressions and some highly unacceptable impressions. And I'd like to see if we can't make a little list of the properties or qualities that both of these sets of impressions have. And hopefully this is going to help you make decisions in your office about whether or not to send a certain impression to a laboratory based on whether or not these characteristics happen to be in place. So let's go ahead and start and take a look at some highly acceptable impressions. Out of these 4 nice or highly acceptable impressions that I'm going to show you, I've prepared all these with the reverse preparation technique and with the 2-cord impression technique. And I'm not going to sit here and tell you that I'm a better clinician than you are. That's got nothing to do with it. It just comes down to the techniques that you use. There's no skill involved if you use good techniques, and that's what I found. And that's what I like about it. I don't like having to be brilliant on a daily basis. Just use good techniques and you'll get good results. So as we look closely here, you can see the margin formation around there. It's a heavy chamfer or a shallow shoulder margin, and you can see the material that extends beyond it. And as we move through these impressions, you'll see more examples of that. Let's take a look at the second impression that we have here. Again, you can see very clear margin formation all the way around. In fact, it almost looks, these impressions should look like they were taken on a Typodon. That's one of the ways that we can tell, okay, this looks pretty good, because it looks like it was done without any kind of oral fluids or anything else. And again, that has to do with the two-chord technique more than my particular skill. But as I look here at tooth number 9, I can see that we've just got some great detail as we look here, and I can see a nice continuous margin all the way around the tooth. I can see it on the lingual margin as well. And I can also, again, see that extension of material beyond the margin heading down into the sulcus. The reason that material is there is we have a double zero chord in the base of that sulcus that's keeping any blood or saliva from contaminating the impression. And you can always tell a two-chord impression because that's what the edge of the material looks like. It is an impression of that double zero chord. And so again, just as we scan over this impression, all the teeth are clearly represented. We've got all the margins visible. And more importantly, we have material that is in the sulcus beyond the margin, and that's an impression of the root surface of the tooth, and it gives the technician exact information about what the emergence profile should look like, and it also shows them exactly where the end of the margin is. So these, again, are characteristics of the highly acceptable impression. Let's take a look at our third one here. You can see this is done. This is a full arch case, full upper arch case, and this is done in a custom tray. I'm a huge fan of custom impression trays. It's some of the best money you will ever spend with your laboratory because you know the tray is going to fit perfectly. You have just the right amount of relief. You know you're not going to bottom out with any of the preps anywhere. And it actually saves you money in the long run because you use about half as much of the expensive impression material when you have a tray that's just got 4 to 5 millimeters of relief throughout the entire arch. So let's take a closer look at tooth number 14 here. I'm just going to zoom in and take a look and see what this molar looks like. And again, this is a really good example of what you can expect with the reverse preparation and the two-chord technique. On this fourth impression, again, we see nice detail, clear detail. I'm going to take a little closer look here at tooth number 11, just kind of zoom in here a little bit. And again, I can see that we've got the margin represented all the way around the tooth. And then we've got that wall of material that extends beyond it. And that's really a nice thing to see. Again, you know, if you picture the impression being in the mouth and that material being down in the sulcus, that is, in fact, an impression of the root surface of the tooth beyond the margin. And that's why, you know, we give so much information to the technicians when we take these types of impressions. I really feel that if you take an impression like this, you can demand perfect or close to perfect fitting restorations, great emergence profile. There's no reason why you should not get very, very nice restorations back from your laboratory with an impression like this. And if you don't, I think you have every right to complain, and I certainly do. Now, on the occasion where I do send a less than perfect impression to the laboratory and they don't quite get it right, I feel like I don't really have a leg to stand on, and they pretty much gave me back what I gave them. But on these highly acceptable impressions, you can be a lot more demanding. And this last impression is just a close-up of one unit from another impression. And this one, just the angle of the photograph shows very clearly. You can see the facial margin. You can see the burr marks on the facial margin. And then again, you can see the extension of the material beyond the margin into the sulcus with no burr marks on it where the tooth has not been prepared. And then you can see how thick the ledge of material is where the impression material was in contact with the double zero chord. So many times if you don't do this, this edge of material is very thin, and when the lab technician's pouring it up, it bends back and forth, but not so with the double chord technique. We have a nice strong wall of material here that resists deformation, and you can see when this is poured up, we're going to see exactly where the margin is. We're going to get perfect information about the emergence profile. If this is not a perfect margin from the laboratory, absolutely send it back. You cannot give them more information about where the margin is than what you see right here. You couple this with a digital photograph of what's going on here and a picture of the temps, and you've got yourself a great case. I mean, there's no reason why the laboratory shouldn't be able to hand you back a really nice fitting, nice looking case. Let's go ahead and take a look at some impressions that do not have these highly acceptable criteria. Here's an impression for a 4-unit bridge from a lower first molar to a cuspid. And the problem with this impression is the fact that it was taken with a double arch impression tray. Double arch impression trays are great for single units or 2 adjacent units, but should never be used for any kind of bridge, especially a 4-unit bridge like this. The other problem with this impression is I roll it over. If you look on the lingual of the molar, you'll notice that we've got some of the tray showing through right at the lingual margin of that preparation, which is unacceptable. We need to have impression material all the way around the lingual margin there and have no tray showing through, especially when it's in contact with the margin of the preparation. Here's an impression where a double arch tray was used to take an impression for a long span bridge. The triple tray, as you can see, subsequently fell off when the impression was poured, and that's not the main problem here because you don't get a lot of rigidity from a plastic triple tray anyway. It's the fact that a triple tray was used for a long span bridge. Let's go ahead and take a look at the models for this case. Here's the model work for that impression. If you take a look at it, you can see that the margins all look good on the preparations. In fact, the preparations are nice, and we've got a nice path of insertion here. But the problem is the impression stops right here in the incisor region. We don't have anything over on the other side of the arch. As a result, when our technicians go to fabricate this bridge, they're not going to be able to put good lateral excursion function into this bridge. So the impression itself is okay, except for the fact that we don't have any kind of guidance from the rest of the teeth. So that makes it an unacceptable impression. This should have been taken with a full arch custom tray on the lower arch. Here's an exercise in frustration. This doctor had to take 4 impressions to try to capture the margins on all the different teeth that were prepared, 2 full arch impressions and 2 quadrant trays. It's very difficult, and no amount of impressions will make up for sloppy tissue technique. And as we look just at one tooth here, we can see a pull coming from the side of there. We can see a pull over on this tooth as well. That's why I prefer the double cord technique that you'll see in this videotape, because it gives me much more predictable results. I don't want to have to take 4 impressions and still not capture all the margins of my preparations. Here's the solid model from one of those 4 impressions, and you can see what the problem is. We've got a nice, well-defined margin as we move along here, and then it just simply disappears on the lingual, and the tissue is sitting up against the margin, and there's really no way for us to be able to guess on a case like this and make a margin for you. The margins aren't much better on the bicuspids as well. So we have a bridge here where we cannot clearly see the margins 360 degrees around the tooth on any of the preparations, and again, the double cord technique could have prevented this. It's hard to find anything good to say about an impression like this. You have to look at it once or twice just to make sure which tooth has even been prepared. It is this tooth right here. There's not much you can say about a visible margin as we turn and look around. There was not 2 viscosities of material used. There was just simply one medium body material squirted into the tray, and it was pushed down onto the tooth. There's no evidence of tissue retraction either. And a lousy impression like this can only give you a lousy model. Let's go ahead and take a look at that model. Imagine for a moment that you're the laboratory technician that this model has been assigned to. Obviously, you're going to have some questions, namely, where are the margins would be the first one that would come to mind. This is going to be very difficult for a technician to guess where the margins are, and this will result in a phone call to the doctor asking for a new impression. This impression, again, represents just sloppy tissue management, sloppy impression taking, massive amounts of pulls and noise and voids and double impressions over on this side. This was a pre-impression that was taken with a putty and was not relieved consequently before placing the light body material in place. As a result, you can see some of the teeth adjacent to the preparation actually have thin layers of the light body material in there, and other ones don't, resulting usually in a double impression. Just not a great impression. Let's go ahead and take a look at the model for this impression. As you would expect, the detail on this model is in short supply. Again, I have a difficult time reading the margin around the entire circumference of the preparation. As we turn it to the side, you can see the result of all the noise and pulls that we had in the impression itself. It's really difficult to get an idea of what the anatomy of the adjacent teeth look like, which is going to make it even more difficult to build correct anatomical morphology into the crown we've been asked to make. This is an example of a good use of an anterior double arch tray because of the fact that we just have one unit that's been prepared here. I can see all the margins as I look around this impression, which is nice. I wish I could see more material beyond the margins, so this tells me that this was done with a one-chord technique rather than a two-chord technique. My one area of concern on this impression is when I hold it up and try to look through it in the area of the bicuspids, I cannot see through the impression material, and that tells me that the patient was not in maximum intercuspation when this tray was in their mouth. So in a case like this, if you cannot see through there, we would ask you to take a separate bite registration and send it along with the case, and we will use that bite registration to mount the models. Let's go ahead and take a look at the model for this case. On the model, we can see the shoulder margin that the doctor prepared, 360 degrees around the tooth. We can also see some anti-rotational grooves that the doctor has placed into the preparation, and you'll see why those are there in a second. As I turn this over, you can see how short that preparation is. If I take a perio probe and mention, we'll see that this prep is just 3 millimeters long on the facial, and it's less than that on the lingual. So we have very little ferrule effect or mechanical retention to help hold this crown into place. What we would prefer to see is have the doctor place a couple pins and a core buildup and build this preparation back down to the level where it should be. Where should it be? Well, if you look at this adjacent unprepared tooth and imagine taking 1.5 millimeters of incisal reduction, that's where this preparation should be, and it's still a good 2 to 3 millimeters short of that at this time. As a result, we're going to have to hope that our resin cement will retain this crown long term. On this impression, I like the doctor's selection of a full arch tray for a 3-unit anterior bridge. That's fantastic. What I don't like about it is that it's a 2-step putty wash impression. I would prefer that the light body material be syringed around the preparations while the putty had not set and it was placed and they were able to set simultaneously. What we see when it's done separately like this is a delamination that occurs between the two materials, and you can see how I could literally just peel this right off, and this will happen all around the periphery of the impression. In thin areas on the inside of the impression, this will pull away as well. So if this is done as a simultaneous putty wash impression, that won't happen when the two materials set simultaneously. As a result, we get some double impressions in certain areas, and the margins aren't always very clear. Let's go ahead and take a look at this model. On the model, I noticed some pulls actually in the areas of the preparation that I didn't even notice on the impression. Sometimes these things are difficult to see on the impression and much easier to see on the model. The other thing I notice is how far subgingival that these margins are. This is always an impediment to taking a good impression when you have margins like this that are placed 4 or 5 millimeters subgingival. This makes it extremely difficult, if not impossible, to get good, accurate representation of your margins in the impression material. Here's an impression that looks very nice. We've got a stock metal tray used for 10 units of full crowns that have been prepared on the maxillary arch. And as I look around, I can see not only the margins, not only the deep chamfer or shoulder margins on all these teeth, but I can also see a small bit of material and extension beyond the margin of the preparation. This is going to capture some of the root surface and allow the technicians to develop a better emergence profile on the final restorations. Let's go ahead and take a look at this model. As expected, we are clearly able to see the margins on all these preparations. It's going to be very easy for the technician to be able to trim these dies and wax correctly to the proper margins. With this type of model and this type of impression, you certainly expect the final restorations to go right to place. These next two cases are highly unacceptable impressions. This first one is for a single unit crown, and this is all we receive from the doctor. As I flip this over, you'll see that it's merely bite registration that was extruded between the patient's two teeth and then relined with some light body impression material. We have no adjacent teeth to go by, no opposing teeth, no real way to get the bite. This is the entire impression sent to us by the doctor. The chances of us making an adequate crown are slim to none. And likewise, on this next impression, this was taken without a tray. This again is a bite registration material relined with a light body syringe material. And this is even worse because this is for a bridge, a 3-unit bridge. And again, we do not have a lot of adjacent tooth information. We have nothing on the other side of the arch because of the flimsy nature of this, and the chances of us making an adequate bridge, it's going to be almost impossible for us to make a bridge that's going to function well for this patient. Both of these doctors will need to be called to take new impressions. I hope you'll find that the reverse preparation technique, the rapid anesthesia technique, and our 2-chord impression technique will not only make you a more productive dentist, but will help raise the quality of your restorative dentistry. If you'd like to take the AGD test for CE credits associated with this DVD, please log on to our website at glidewell-lab.com. And I'd like to thank you for your time and your continued commitment to quality dentistry.